A 27-year-old premigravida woman was transferred to theatre as a Category 2 emergency after sustaining a 4th-degree perineal tear during instrumental vaginal delivery. To begin the repair, the rectal mucosa and submucosa were sutured with 2O-vicryl, with the mucosal knots lying on the luminal side. In 4th-degree perineal tears, every layer has an injury and every injury has an apex. The repair of each layer should begin at the apex and work outwards. The rectal mucosa was then examined to ensure that the repair was complete. Using sharp dissection, the vagina and the muscle coats of the rectum were dissected from the perineal body. This allows for closure of the muscle coats of the rectum. The rectal mucosa layer can be seen pouting through on digital examination. The internal sphincter, which is in continuity with the circular muscle layer of the rectum, was repaired using 2O-vicryl in an end-to-end fashion. The retracted ends of the external sphincter were then identified and mobilised to prepare for the double-breasted repair. Care was taken not to over-mobilise the sphincter, which would risk denervating it. The nerves enter at 2 and 10 o'clock. To ensure that the correct muscle layer had been identified, the crossover squeeze test was performed. A digit was placed inside the rectum, with traction applied to the two ends of the external sphincter using Alice forceps. An appropriate amount of pressure was felt on the examining finger. Once the external sphincter was correctly identified and mobilised, the anal verge was closed. Closing the anal verge at this stage avoids putting any unnecessary tension on the skin after the sphincter is repaired. It also provides a bed for the repair. The next step is to repair the external anal sphincter. The two ends of the sphincter were approximated using a double-breasted Mayo-type repair with 3O PDS sutures. 2 rows of 2 sutures were positioned in a mattress fashion. Placing the sutures perpendicular to the muscle fibres ensures that they do not pull through. The double-breasted repair is robust and gives bulk to the sphincter. This prevents thinning of the muscle once healing is complete, thus improving early continence. This patient was fully continent at a routine 6-week checkup in the clinic. Specialist follow-up demonstrated normal anatomy, and an endoanal ultrasound showed intact, normal-appearing internal and external sphincters. She is currently undergoing biofeedback for pudendal neuropathy in order to improve her long-term outcome. The final PDS suture was placed, completing the double-breasted closure of the external sphincter. The muscles of the pelvic floor, including bulbocavernosus and the prerectal fibres of puborectalis, were then repaired using 2 ovical sutures beginning from the apex. The 2 ends of the transversus perineus muscle were sutured using 2 ovical. As these sutures were tied, the perineum was closed and the defect became much smaller. The superficial perineal muscle was then identified and closed in order to give extra bulk to the perineal body. The vagina was then repaired, beginning with the deep layer. A 2 ovical suture was used for everything except the external anal sphincter, which requires 3 OPDS. And for the skin and vaginal mucosa, a 3 ovical repeat suture was used. The layers of the vagina were then examined in order to properly reconstruct the introitus and give a good cosmetic outcome. The vaginal mucosal injury was then sutured using 3 ovical repeat. Here you can see that the vaginal mucosal injury has been completely repaired. Subcutaneous perianal and perineal body sutures were then placed. And the labia were then repaired with subcutaneous 2 ovical sutures. This was followed by 3 ovical repeat sutures for the skin. Further subcutaneous suturing was required to complete the reconstruction of the introitus and to bring the skin of the perineum together. Finally, a digital examination confirmed that there was no rectovaginal fistula and that the repair was sound. Postoperatively, the patient received 5 days of intravenous antibiotics. She was seen by pelvic floor physiotherapy on day 1. She passed flatus on day 2 and a bowel motion on day 3 and was fully continent for both. She was discharged on day 5 with instructions to take 1 month of lactulose, and she was advised to undergo caesarean section for all future deliveries.